Hello everyone, welcome back to Hot Seat Season 3. It's Omid Moghaddas from Tehran. And once again, I'm so happy and grateful to have the chance to share this educational platform with all of you, with all my dear guests and great educators from around the world, who I'm very fortunate and very honored that they accepted the invitation and are sharing their knowledge, their time, their skills with all of us through this platform. And today I have a very, very dear friend joining me from United States. Dr. Peter Amin is here with me. Hello, Peter, and welcome to Hot Seat.
Hey, Omid, how are you?
Thank you so much for joining. Thank you so much for accepting. You know, over the past parts and sessions on Season 3 of Hot Seat, we tried to go through case presentations and open up the concept that we reviewed over the past 2 seasons. And today, you are lucky to listen to a very comprehensive presentation by Dr. Amin, because it's going to be a complete review in the field of bone augmentation procedures. We will go through the basics, whatever things that you need to know for increasing the success in your treatments. And definitely, we will have a case presentation during his presentation for making it more understandable for all of you. But before we start, I would like to have Dr. Amin's CV for all of you as a tradition of Hot Seat, and then we will go to the presentation, and at the end of it, for sure, we will have a quick discussion on the topic. Dr. Peter Amin received his bachelor's degree in dental surgery, BDS, and AEGD training from Ain Shams University in Cairo, Egypt. Practiced general dentistry for another year before moving to Cleveland, Ohio. In 2013, he completed his periodontics fellowship program at Case Western Reserve University, followed by a residency program in periodontics with special focus on dental implantology and tissue grafting around teeth and dental implants. On top of being the chief resident during his residency, he won first place award at the Graduate Student Research Forum in the Midwest Society of Periodontology annual meeting, Dr. Nabil Bisada Award for his research during his residency, and was also top abstract winner at the University of North Carolina Golden Jubilee Periodontics Expo meeting. To maintain his teaching and research interest, he currently maintains as clinical assistant professor position in the postgrad clinic Department of Periodontics at Case Western Reserve University, as well as private practice in Cleveland, Ohio. Dr. Amin lectures internationally and is a diplomate of American Board of Periodontology and also a dental expert. Once again, I'm so happy that you accepted the invitation, my friend. We're truly looking forward for your beautiful presentation, and the platform is all yours.
Thank you so much, Omid, for the presentation, for the introduction. Very nice introduction. Thank you also for asking me to come here. I was really looking forward to it, and I've been following the Hot Seat and very nice presentations with big names. So I'm humbled to be part of the Hot Seat Season 3. And let's start first with our presentation. Today I'm going to go over the techniques of bone augmentations in implant dentistry. First, I want to go over where I'm from. As Omid had said, I'm originally from Egypt. This is a beautiful Cairo, where Ain Shams University is. And then I moved all the way to Cleveland, Ohio, which is the northeast of the United States, to Case Western Reserve University. And this is beautiful Cleveland. So how important is bone grafting in implant dentistry? Many articles have tried to say how much bone we need. And there's kind of a consensus that at least we need 2 millimeter bone thickness outside the circumference of each implant. Spray and Grunder are the main articles that mention the 2 millimeters. Now, before we start into augmentations, I would love to go over the preservation as an even important topic. We will see how with many different techniques we can grow bone, but if we can preserve bone, that's going to be even more predictable and more easier. So ridge preservation is the first step when we take teeth out, putting bone graft, and partial extraction therapy, which is now is like a rising topic that really can save much more bone compared to just ridge preservation. Because with partial extraction therapy, we preserve the PDL, which preserves the very thin buccal plate of bone. I'm going to go over a couple of cases with the partial extraction therapy. Avoiding tissue-supported prosthetics. And for me, that was a key to the success of many cases, especially the fully edentulous cases. Sometimes it's hard to convince patients to avoid using dentures during the healing time, but this was a big dramatic change in the results compared to when patients are wearing more removable dentures or partial, especially if they are loose fitting. Stage approach for chronic periodontitis cases, especially the full mouth cases. I've seen a big improvement in the augmentations and less bone loss when we do them staged, which I mean taking out teeth first. And this is mainly for the chronic perio cases. Taking out the teeth first and doing with their GBR or rich preservations and waiting few months after all the bacteria have much decreased, and then we can go back and put the implants. This is not the case, for example, if the teeth are broken or with a lot of decay. Use of biologics, I'm gonna touch base on these. But how do you measure success of bone grafting? So before we go into bridge augmentations, when should I say this grafting was really successful? How we can measure the success? How we can say, oh, I got 100% of what I was looking for, or 50%. So unfortunately, in the literature, there's no enough data on how to measure it. Right now, what we actually do is we see if we have enough bone to place the implant in the ideal restorative position, we say it's successful, which is pretty valid. Implant survival, that's most literature. They say if the implant stays, then the bone grafting was successful, but this is actually not very valid, because we know now that implants can stay with even as little as 2 millimeter bones holding the apex of the implants. So if you go into the literature, unfortunately, you not find a good valid calibration for the success of bone grafting. Bone stability long-term, this is very important, but unfortunately, it's not published yet. So if you look into a vertical augmentation, especially, these are the hardest ones, and you see how long the bones take. If we're trying to compare, for example, block grafts versus titanium meshes, 10, 15 years, did we lose some bone? This would be a really good study, but unfortunately, up to now, no comparisons between different vertical augmentations on the stability long term. For example, this one of the augmentation, this was 3 years after vertical augmentation was done, with bone looking very nice. But how will it look in 10 years, 15 years? I really don't know. How much bone can we gain? Now, this is it's a very repeated question that people want to say, I want to do vertical augmentation. Can I gain 6, 7 millimeters of bone? Although there is no limit, but let's see what's the average. So Jensen said that with non-resorbable GBR, you can get non-resorbable barrier. You can get 2.5 to 3.5. With resorbable, he was able to get more, according to that study in IUGME, 3.2 to 4.6, and with block autografts, that was the highest. So 4 to 5.7. Now, Milenkovic said that ridge split, you can get 2.9. With GBR, particular GBR, around 3, with block grafts for 4.3. So it seems there is a consensus that maybe 3 millimeters is an average number, and it goes a bit higher when you use block autografts. So 4 to 5 with block grafts. But this is depending on the studies that were published prior to these articles were done. But we can see that we can gain actually much more with certain techniques, but we have to know first how to use them and where we can actually pick each technique in a specific situation. First, without going into details, I want to first know what are the defects that we're every day seeing in every case. Colombia classification is kind of the basic classification that we have to know. It helps with the communication. It also helps us with understanding how to deal with every defect. And that was from the 8th European consensus in 2013. So there are 4 categories: H for horizontal, V for vertical, C for combined, and these are the most difficult cases to treat, and S for sinus cases. And then class 1, 2, and 3, depending on how deep the defect, 1 to 4 millimeter, 4 to 8, or more than 8. And then a very important part is it internal or external? Is it inside the bony contour or outside? That is the last thing. So looking at the classification, we almost go over all these defects with different patients, but some of them are much more difficult and much more sophisticated in treatment them versus, for example, treating a horizontal class 1 versus combined more than 8 millimeter defect outside the bony contour. Now, what are the requirements to obtain good bony augmentations? Space maintenance, which is a scaffold. If we have all the walls, that would be great. If we're missing 1 or 2 walls, do we have a membrane to keep the bone graft in? All these are important factors to have very good augmentation results. Protection in a closed environment, which means having a primary closure or tension-free closure. Bone forming cells, which is the key to the very good augmentation with very long-term stability, is having bone forming cells. These are the cells that are responsible for the new bone production, which is angiogenesis. And then wound stability, which is the part that probably the removal prosthetics makes it much more difficult to do. Now, what are the techniques available for guided bone regeneration? We have block grafts. These are the most commonly used in literature, and these are one of the oldest ways of ridge augmentations, whether autogenous, xenografts, or allergenic. And then the Corey plates by Dr. Corey, and these are very similar to the block grafts, but instead of using the whole block, we use a very thin plate, and then between that plate and the native bone, we use autogenous particulates. The main advantage of the Corey plates, it decreases much the resorption, and also you can gain much more bone. GBR cases, which is probably the most commonly used, with the use of particulate grafts with the membrane, whether resorbable or non-resorbable, and we're going to go over different membranes, how we use them, and what we should expect from each of them. And then ridge split, it's also a very old technique, and has definitely some room clinically. And then ridge expansion, and one of the techniques is the osteodensification using the VersaBurs, which I think is a game changer and improved a lot the quality and the easiness of doing a lot of the GBRs and generally implants placement. Then sinus lifting with different techniques, and then distraction osteogenesis, which is a very old technique, but there's a lot of costs in it, and there's also a lot of issues with using distraction osteogenesis. We're going to cover it as well in the presentation. And then orthodontic extrusion, which is a very, very predictable way to gain bone, and unfortunately not much used. A lot of people, they don't know about it, or they don't want to go through it, but orthodontic extrusion is a very valid, predictable way to, especially in the upper anterior region, to gain back the lost bone. And then you can use combination of any of the above. So many cases, I'm doing ridge expansion with a GBR. I can be doing ridge split with a GBR. Corey plates with another technique. So we can do sinus lifts with other GBRs in the same area. And this is the beauty of dentistry. There is no one technique. There is no one way. There are different ways, and with every case, there is a challenge. And the way we think about it is very important to get the very good results. So what are the membranes available in GBR? First, the collagen membranes, whether cross-linked versus non-cross-linked, the pericardium, which is also the resorbable membrane, titanium meshes. There are two different kinds of meshes, polished versus non-polished surfaces. Also, there are ones with bigger holes versus smaller holes. Titanium reinforced PTFE membrane, and the most commonly used one is the cytoplast. And then the PTFE membrane, but not reinforced. They're plastic membranes, but there's no titanium in them, so they don't retain the shape that you shape them into. Tinfoil used to be used in the past, but no longer used. Then PRF, can it really be used as a membrane? With much, I use a lot of PRF with much improvement in tissue healing, but it cannot really be used as a membrane because it only stays for a few days. So it can be an adjunct to some of the other membranes, but it cannot be used solely as a membrane for GBR. So what are the factors affecting the decision on the technique? There are many techniques. On what basis I choose a technique? First, is it a small defect versus a large defect? This one you see here is a large maxillary defect. You can see part of the palatal wall is even broken, which is not a very common thing. This is a combined defect with the vertical and horizontal components. So mandible versus maxilla. This is you can see there's a big difference in dealing with the mandible versus maxilla, the flap advancement, how often we see like big mandibular defects that are very, very hard to treat. Maxillary one is easier, but each one there are specific techniques that can work and work really well. And we'll go over that. Outside versus within the bony contours. As you can look at this this picture here, you can see the bony contour on the left side is high versus on the right side is much lower. If we have high interproximal bone height on both sides of the defect, this is a very predictable, nice case to deal with, versus if we lost the interproximal bony height. Sometimes we need to do an extraction of one or two teeth to make the ridge augmentation much more predictable. Are we placing implants at the same time or not? For a case like that, placing implants simultaneously will decrease a lot the success of the results. We know that implants are avascular surfaces, and placing them, not only you put the implants at risk, but also you can decrease the amount of bone augmentation. Versus some cases, you can actually place the implants and do the GBR at the same time. How many walls are we missing? What is the type of the provisional prosthesis? Many times with the especially upper anterior, even for one tooth edentulous patient, patients go with flippers. I always try to avoid using flippers or partial dentures. Using something simple as an Essex can improve a lot the tissues and the bony augmentation. Patients' acceptance and expectations. So how long will the GBR take? What is the cost? Are we using autogenous grafting? Are we doing maxillary GBR with a mandibular block? The patient okay with having multiple surgeries or multiple areas? All that is important in deciding which technique I'm going to use. Also, patient's medical conditions. Is the patient in a good health to go through big GBRs, or should we be more conservative? Horizontal versus vertical. And then presence of scarring or filled implant site. Now, this can be one of the most challenging GBR or even any periodontal surgery to work in an area that have been worked on before. First, it failed, and then whenever there's a failure, the tissue doesn't heal as nicely, and then there's scarring of the tissue, and it affects the blood supply to the bone graft or the implant. Plus, usually these tissues are not easily to stretch to cover the new GBR. So these cases, you can't jump into them right away. You have to first study the case, study the scarring, see how many surgeries were done before, and study the CBCT well. So all these factors can affect the decision, which technique I'm gonna use, and with each technique, how long I'm gonna wait before I open and place my implants. And then the clinician bias. Of course, you'll always see some clinicians leaning towards a specific technique, which is totally fine. This is not something wrong. You're not supposed to master all the techniques. Mastering 2 or 3 techniques, and then you have to be aware with the other techniques. This is the key to success. You don't have to use all the possible techniques that are invented in your daily practice. So which technique offers the best results? This is the question that came into my mind when I was introduced to all these techniques. Like, I just want to know what is the best technique, and I want to use it and get the best results. But you find that there is no literature supporting any specific technique. Pascal said that There are many techniques that can offer very good results, but there's no specific surgical procedure. Agaloo, the same thing. Many techniques have very comparable results. Just we have to know that the block grafts have the oldest literature. So using autologous blocks, you can go back many years ago and you see them reported with probably the longest follow-up. But still, many techniques have been shown in the literature and clinically that you can get very good bone augmentation with very good results, with long-term results. So what we expect with vertical techniques, we have to understand how each technique works. So in vertical bone augmentation, bone blocks have the least healing time. So in 3 to 4 months, you can go back and place your implants in. They have very less cost because you're using patient's own bone. They have better bone quality. But the problem with them is you have a second surgical site, and the surgical time might be a bit more, just because you're doing 2 surgeries, one to harvest the bone and the other one to place the block grafts. Now with titanium meshes, you can gain large amount of bone. There's a higher rate of exposure, although this is operator influenced. So many of the literature that they show you, there is some titanium meshes exposure. You'll see that it's one surgeon has been doing the surgery. Honestly, with using titanium meshes, especially after you master the technique, you find that the rate of exposure is extremely low. As long as you know how to use the meshes and how to handle the tissues, their exposure is extremely minimal. But they need more healing time, definitely, and removing them is difficult. You have to access all the membrane to remove all the screws and the buccal and the palatal, versus with other techniques, the second surgery, you can just open very small surgery and just expose the bone and place the implants without photo-flexion of the buccal and palatal flaps. Other non-dissolvable barriers, they have less morbidity. Chances of exposure is lower, especially if you don't have a lot of experience with them, but they have higher cost and more healing time is needed. I have to just say that with one non-dissolvable barrier, which is a cytoplast, these membranes, these are occlusive membranes. Once they get exposed, you will see the flap almost sliding over the membrane. So the chances of the membrane itself to be exposed is low, but once it's exposed, there's a problem with it that you have to know that the flap will start sliding all over the membrane, and you can see the whole membrane exposed within a few weeks from the start of the exposure. Versus titanium meshes, you can see a very small area of the membrane. For example, if sharp corner of the membrane perforated the tissue, it can stay the same for month on month without the whole membrane being exposed. Actually, the way the titanium mesh is, you will see interlocking mechanically with the flap, and that actually would prevent complete exposure of the membrane. And then distraction osteogenesis, it has a very fast healing, so less healing time, but there's a high cost, and many times there's a need for additional grafting. And one important thing is you have to look at the tissue before jumping into bridge augmentations. So I'm one of the people who love a lot doing tissue grafting before doing bridge augmentation. This is one case where a patient came to me. He was a retired colonel in the army, 84 years old, and 2 implants were just fell off. And he's telling me, like, can you please put back the 2 implants that were just placed a few weeks ago? And looking at this case, I was like, oh, this is not definitely a case where I'm gonna place the implants right away. You lost a lot of bone, you lost a lot of tissue, you have a lateral incisor that needs to come out. And patient said, no, I'm not gonna remove any more teeth. Try to place the implants without removing any more teeth. I wanna save all my teeth. And you can see he has a lot of dental work done in his mouth. Almost each tooth is either crown or has some kind of treatment done to it. So that case, with all the scarring, we cannot put the implants in. We cannot even do GVR right away. So we decided to do tissue grafting first. And this is super painful from the scan. You can see huge vertical and horizontal defect. In this case, I did back when I was in residency, and for me it was a very complicated case. But when you break it down to step by step and fixing each problem at a time, you will see how we're gonna reach a very good result. So look at the area. There's just a split thickness flap. You can see how the tissues are very inflamed, and this is all granulomatous tissue from the failed implants that actually fell off. This is a large tuberosity graft that was taken and placed at the edentulous area after we did the split thickness, and then we used chromogat sutures to stabilize the graft. Chromogat are very nice sutures. Right now, I'm more inclined to using non-dissolvable stitches, especially monofilaments. But this one healed, and then you don't have to wait till the graft totally mature. I mean, it can take 3, even 6 months for the graft to totally mature, but actually after 4 to 6 weeks, the graft is already integrated and there's already good attachment and it's part of the flap. So while it's still healing, you can take advantage of all the angiogenesis and the new blood vessels that are forming and go ahead and start the GBR. This is where the graft was taken from. So this is before the free gingival graft, and this is after. You can see we gained a lot of thickness. We restored the lost vestibule, and now we're ready for the next step. So we open the flap, and you can still see the areas where the implants have failed and have fallen. A lot of granulomatous tissue. And then once we cleaned all that stuff, we see like even the palatal plate is broken. So in this case, I decided to use a cytoplast, and this is a mix of allergenic xenograftic mix. And then we use 3 screws, 2 screws in the buccal and 1 screw at the crest. And then because, as I told you, the cytoplast, as good as it and as nice I like it, but the problem with the cytoplast, if it got exposed, the flap will start sliding. So to protect that, I wanted to get a palatal pedicle graft to cover the suture line. So this is a partially dissected palatal pedicle that's still attached to the palate, and then that will go over the top part of the membrane. So even if the suture line got exposed and the flap started opening, there is a second line of defense from a very thick connective tissue that would prevent the membrane from getting exposed. And then at that time, I was using Vicryl sutures, but also right now, I don't use any more dissolvable sutures with any regenerative procedures. And then this was after 5 months, very nice tissue, very thick bone. And then we opened, we're removing the screws. You can see we have very good bone over there. And this is the inside of the cytoplast membrane. Then we went back and placed 2 implants. Actually, it was very good torque, so I put the healing cap at the same time. So this is before, and this is after. The interesting part that we're able to even get some bone coronally on the avascular tooth, mesial tooth defect. This is not something we predictably do or something we will do every time, but this case, the patient didn't want to take the tooth out, and actually we're able to save it by growing some bone vertically on the distal part of that tooth. And we placed the 2 implants, and after a few months, they were ready to be restored. Now, the use of biologics, PRF, especially the recent article, said that they can improve a lot the tissue healing, but there is no real improvement in the bone defect. So whether you do sticky bone, IPRF, or any kind of PRF you add to the bone graft, you have to know there is no added benefit. But using the PRF can improve the healing of the tissues, but you will not expect faster bone healing or much improvement in the bone quality. You still, your technique and the way you handle the tissue and the way you handle the membrane and understanding the biologics behind it is what's going to make the success. Now, PDGF, which is GEM21, this is a very good material that can be added to the bone graft, but you have to know that only case reports have been used. I use it a lot, and very good results. And you can actually open augmentations faster and earlier. But you have to know that this is not the way they were invented for, and they were invented for periodontal defects. So you have to tell patients that this is an off-label use. Same thing with BMPs, which is, for example, Infuse. There are a few studies lots of case reports done on them. And also Infuse is a great material, but it has a lot of cost in it, and bone morphogenic proteins, they cause a lot of swelling. So looking into, this is the FDA approval for both of them. If you look at Infuse, it's used actually for degenerative disc disease. And then for GEM21, it's actually approved for intrabony periodontal defects, for Caucasian periodontal defects, and for gingival recession associated with periodontal defects. It's funny that almost no one uses GEM21 for periodontal defects, and most people actually using it either on implants or for GBRs, which is fine. I personally use them both in GBRs, but you still have to ethically and I think legally tell the patient this is an off-label use. Now, finally, flap release and suturing. And I think most of the problems I've seen with GBRs, with their cases I've done myself or for other people showing failures, the flap release and the suturing has a big role in them. Primary closure and tension-free, that's the key, is the main reason for success. Like for that case, on the left side, this was a titanium mesh, and the same day, after we added lots of bone, we got tension-free closure, and I used polypropylene for this case. On the right side, I was in the second stage. There was no reason to do something like polypropylene. So we opened with the implants. We didn't need to release the flap because we didn't add any more bone. We just removed the titanium meshes, placed the implants. I used continuous interlocking suture with chromic gut. If I use the same suture for the first surgery with the GBR, I would have had a big failure and exposure of the membrane. So we have to understand what sutures I want to use, what should I expect. Does the surgery involve a lot of swelling, like most GBRs are? Then I expect the sutures will be torn away if there's any kind of stress on the flaps. To resorbable versus non-resorbable, I'm leaning more now towards non-resorbable with any GBR, especially when I know that there will be a lot of swelling. You have to know also some sutures are slow resorbables, like polyglycolic versus like fast resorbable ones like chromic gut or even gut, which doesn't stay 3 days. And then monofilaments are much better than multifilaments in terms of the hygiene. So polypropylene, nylon sutures, PTP, all these sutures are much cleaner compared to Vicryl, which is a slow resorbable multifilament suture. Now, stabilization of the membrane. There are many ways to stabilize the membrane, and each membrane has specific requirements. So for collagen membrane, like in the left or the right picture, these ones, you can be stabilized with either screws or with sutures. And these sutures, like you see in the left side, we can actually retrieve them from outside the flap. So at any point I want to remove the sutures, the knot is outside the flap. So I can just cut below the knot and I can grab the whole suture out. Now on the right side, the knots are underneath the flap. So for that case, I know that the sutures, I want them to stay for the whole time and they'll not be able to retrieve them till I open back and place my implants. Now, in the bottom picture, these are non-dissolvable barriers. These ones, you cannot really use sutures. You have to use either tacks or screws. And the tacks and screws, you can remove them at the time of the uncovery. If you're doing block grafts, you can actually leave them after the block healed and they can stay forever. So you have to know what technique are you using and what membrane are you using. And the most important key is the membrane has to be very, very stable. If you can move the membrane before the flap closure, definitely it's gonna move. Because what does happen after we close the surgery? Within 2 to 4 weeks, a huge amount of swelling will occur, and all that swelling and edema, the body is trying to know what's going on, and a lot of inflammatory cells are in the area. All these will expand the bone, will expand the membrane. If the membrane is really, really stable, then it will not be affected. And also, and only that swelling will show in that. But if the swelling moves the membrane or the bone tiny bit, then forget about the quality of the bone you're gonna get. You're gonna get very mushy, very friable bone. Even if you wait for a long time, still the bone will not be as good as very rigid, stabilized membranes. Now, horizontal augmentations, the way I look at them, and I kind of put them in three different categories. Mild defects, these ones you can do ridge splits. At least 3mm bone has to be present. You can't do it if there's only 2mm bone or less. And then what you do is you can also use expansion like Versa. Moderate defects, where you can do GBR, whether it was resorbable or non-resorbable. And these ones you can actually do simultaneous implants. If I have like 4 or 5mm bone, I can do simultaneous implant placement with GBR. And then severe defects. These ones you have to use something that's really invasive, like block grafts, Cori, or titanium meshes. So depending on how much bone is present, I look into these three different categories and I decide which technique I'm gonna use. Now, with splits, we can use either piezo or we can use surgical sew. If it's not available, if I don't have the piezo unit or I don't have a good surgical sew. A very thin needle, but surgical length. The one similar to the ones the open the contacts when the restoratively do crowns can be used to do a very thin line within the crest of the bone, and then you can use expanders, whether Versa or different expanders to expand the bone. Of course, piezo would be a better option because it saves that bone, but very thin needle, probably 0.5 millimeter thickness can be used. Now with vertical bone augmentation, if it's mild or moderate defect, GBR with non-resorbable barriers can do very good results. For severe defects, blocks, Cori, or titanium meshes. Now, although you can gain also some vertical augmentation with sausage technique, but in my hands, I found it's more predictive to use non-dissolvable barriers, especially for vertical augmentation. Now, if we look into the efficacy of horizontal vertical augmentations, you see that various techniques have been used, and there is no evidence that one technique is more preferable. So up to now, this is a study by Esposito, and in his systematic review, he couldn't find any literature saying that one technique specifically will be more preferable. So still, clinician bias will play a role in the success. And the same was for horizontal. So vertical or horizontal, still different techniques can be used. And if you ask two different clinicians, they will tell you two different answers. But you have to know that complications are more common, especially with vertical ones. And with every technique, you have to think about the benefits and risk. So don't just jump into doing a procedure without looking to the whole picture and weighing the benefits and risk. And if we can do it more conservatively, definitely making the patient go through less complications and less side effects would be preferred. Now, case selection, patient's expectations. This is a case with a fully edentulous patient. So he was okay with going edentulous and not wearing a denture. He already has a denture that's loose, ill-fitting, and he's okay staying like that for 8-9 months. So for a case like that, I can go ahead and do big GBRs. I'm confident that I'll get good results because I know that the patient is on my side. But if a patient is not accepting specific requirements, some cases I have to tell the patient I can't help you. What I need certain help from the patient and from his expectations. If the patient wants to get the implant restored within 4 or 5 months and we need to do a big GBR, I can't do big GBR and go back in 2 months and open and place my implants. If the patient is not on the same page with me, then sometimes we have to abort or decline the case. Or if we can educate the patient and change their mind, that would be actually perfect. Now, how long can we wait or should we wait after GBRs? That question, actually, there's no answer. Depending on what kind of technique we use, how much bone we placed, patient's age, maxilla or mandible. But in general, we have to just have a key point in our minds that block grafts, autogenous block grafts and Cori, they heal much faster. GBRs, whether particulate or allogenic blocks or the immunogenic block, all these will take much more time. And vertical augmentation takes more time. I would say 5 to 7 months is an average time. Sometimes I wait more, but with core techniques, I can 3 months or even 4 months, I can go back and place implants very comfortably. Now I'll go over a few cases and we'll see different techniques that were used and how we handle each case differently. So this is a case where a patient with severe decay. 3 of the anterior teeth are non-restorative because of the deep root decay. And then we're able to save some of them with some restorative work. Patient also has very poor oral hygiene. So before we started, we work on the patient, improving the hygiene to make sure that whatever technique we use is going to work. So I started by doing socket shields, and that was for two centrals and one canine. And then what happened after I cut the socket shield and I'm ready to place the implants, I found that the implants go deeper. And I use the longest implant I have, which is 16 millimeter, and still the implants are very deep. So I have 2 options here. Either increase the implant diameter and go with a very large implant and jeopardize the success of the pet with the socket shield and also having bad aesthetics, or I decide to do a blocker approach, which is a 2-stage socket shield. I'm going to first do the socket shield, put the bone graft, and I'm not going to place the implants till the bone graft heals. So we put the bone graft in here and then PRF membranes, and then we went back 3 to 4 months, and then we opened. You can see the nicely shield, but we also have to adjust the shield a little bit after we open the flap. At this point, I'm comfortably opening the flap. I need to see exactly what the shield is. I know that the bone is intact, the bone is preserved, and I want to see the quality of the bone that we got. So we adjusted the shield a little bit, and then we placed our 3 implants comfortably, 2 millimeters away from the socket shield, and then we buried the implants, and then this is the final. So very nice thick tissue. Also, the patient improved his oral hygiene and is ready to be restored, and we're storing the 3 implants along with a crown for that lateral tooth. Do I always do that? No, it depends on the case. If there's a need to wait, I don't hesitate to tell the patient, sorry, we have to wait extra 3 to 4 months to get a more predictable and successful result. And I started with that case because, as I tell you, the preservation is the key. If I always can preserve the bone, will be much better than, or much more predictable than trying to augment. This is the case, lower mandible, posterior area, where you can see very thin ridge defect. So I use cytoplast with screws, and then primary closure, tension-free. And I use some decortication, but you have to know that there is no evidence that decortication does any improvement except increase in the mechanical locking. So in that paper, you will see that there's conflicting information and not enough clinical trials to see the merits of bone decortication. I know very good clinicians that tell you they never do decortication, they get very good results, and some they do it and there's no difference. So you have to know that till now, there's no proof that decortication does a major improvement. And then we waited 5 months, we removed the membrane, and then we have a very thick ridge that we can place our implants comfortably. 3 implants were placed in the posterior mandible, and then they were restored. And this is 3 years outcome. Very stable results, no bone loss. Now, after 10 years, will it look the same? I don't know, honestly. I mean, I have to follow up and see, but restoratively, it looks good. Hygiene, patient looks very good. Good attached tissue, keratinized tissue around the implants. All these should lead to good success, but we have to follow the case for long term to see the results of the augmentations. Now, this is a case I just mentioned about edentulous maxilla. Patient denture doesn't fit. We open the flap, very thin defect, especially in the top right side. Bilateral titanium meshes, primary closure. I use a mix of allograft, xenograft, either 70-30 or 50-50. Both of them were mentioned in the literature. And this is a scan taken just before we we remove the titanium meshes. Then we remove the titanium meshes, and you can see almost we got all the bone that we put in, and we remove the membranes. The bone looks very solid. I was able to put 4 implants, and then decide to bury the implants. Still don't want any pressure on them. And then in the uncovery, we decide to do apically positioned flap with free gingival graft. This is free gingival graft taken from the palate, from the tuberosity on both sides, and you can see it covered the whole buccal area. And this is the final down there. And this video shows how strong the bone is. So this is not a soft bone. This is not D4 bone. This is definitely a very strong bone that you can place the implants with very high torque. Another case, edentulous maxilla, but this case is even more challenging, was very thin knife edge maxilla, but also part of the bone is actually broken. You can see in the top left side, when the teeth were extracted a long time ago, all the buccal plate and the palatal plate were broken. So with time, we lost all the bone over there. Now for this case, there's no vertical height in the posterior, so we decide to do bilateral lateral sinus lift, as well as titanium meshes at the front and premolar area. And that case is still in process, so I'm waiting at least 7 to 8 months. Although the GBR itself, I can go back in 5-6 months, but for the sinus lift, 6 months is the least. I prefer 7 months or even 8 months. You will see a big difference when you wait that extra month, especially in the big lateral window sinus lifting. There's another case here, mandible posterior area, very thin defect, very thin ridge, and we decided to use Cori plates. So 2 Cori plates were used from the same area, mandibular ramus. And then after putting 2 screws in each plate, I found there's a very minor movement. And as I mentioned before, the key to these cases that you have to have very good stable, whether it's a membrane or a Cori plate, there has to be very, very stable. So I decided to add a 3rd screw. However, you have to be very careful with adding the 3rd screw to not break the plate. So the thickness of the plate, the area where the screws are, and the width of the diameter of the screw plays a major role. You can easily, and I've had it before, where if the plate is very thin and the screw is very close to the end of it, you can see the plate actually breaking, whether at the time you're drilling or when you're tightening the screw at the end. And this case is also in process. And as I said before, the flap handling is very important. So for that case, we have to elevate the lingual flap and use this to an urban technique. You can read about this very, very nice technique that you can predictably raise the lingual flap lots of millimeters. And this is very important for primary closure tension free. So you can see the lingual flap raised very comfortably, very safely. And then these are 6/0 nylon sutures with a primary closure. Conclusion to this presentation, autogen is still the gold standard. That doesn't mean I'm only using it, but you have to know that this is the ideal, much more predictable augmentation. Alternatives are also very valid. There's a learning curve with any technique you use. You can't just see a video or a study that published and try to do any technique. You have to know there's a learning curve, and you have to know the basics before you jump into doing large augmentations. Experience level is very important with specific technique. And then you don't have to master all the techniques. You have to master a couple of techniques that use them comfortably, but you have to make yourself familiar with the others. And that's pretty much it for my presentation from Cleveland, Ohio. I want to thank you all. This is my little family here. Thank you, Omid.
Thank you so much, Peter. Thank you for, as I said at the beginning, for this comprehensive presentation on bone augmentation, because really the point that you also made in the conclusion is that no matter what technique we choose, the principles are the same in all of them. So if we know the principles, if we select the case properly, we can maximize the predictability of our results. And that was what you showed very clearly and very comprehensively. So thank you for that. You can stop share now if you want, and we can have a discussion on the topic.
Sure, sure.
Your topic was also very interesting. I actually want to know
Thank
your
you.
comments on some questions that I might have, and it may be common with our audience. You know, titanium mesh is one of the great techniques in augmentations, in vertical and horizontal, and maybe in vertical augmentations, it's more demanding comparing to horizontal, because in horizontal augmentation, we have so many techniques that maybe even can work easier. But one of the concerns that usually people have about titanium mesh is its exposure, which me personally, I really don't think it's the problem with the mesh, but maybe because it's rigid, the risk is going to be higher. So
yes.
I want to know your recommendations, because especially those two cases that you showed was massive cases, and the quality and the quantity of the bone that you gained was amazing. So I want to know your recommendation for those people that want to try titanium mesh or had any negative experience with titanium mesh, especially in those massive cases that usually when the patient has lost so many teeth for so many years, the tissue has collapsed, the ridge has collapsed, the tissue maybe does not have good quality. So how they can increase the predictability of using titanium mesh and how they can minimize the risk of exposure?
Yep. A very good question, Omid. So I think there are multi-factors that we can add that will decrease the risk. Is the flap is very thin. Adding a free gingival graft prior to the augmentation can help a lot. Cutting the membrane and making sure it's not very close to any nearby tooth, leaving at least 2 millimeters is very important. Usually what I've seen, the sharp edges at the corners of the membrane that start getting exposed. So making sure these sharp edges are cut and they're inverted towards the bone, not everted toward the flap. Also using a prosthesis, many times there's a flipper involved, and hitting the flap a lot and then making the titanium perforate the tissue is also, I've seen it a lot and it's very common. Lastly, which is, I haven't touched on it, but thank you for asking it, putting a collagen membrane on top of the titanium mesh also decreases the exposure. So I've done it both ways, using just the titanium mesh without putting any collagen membranes on top. And I've seen putting a collagen membrane on top actually decreases the risk of exposure. So I know there's added cost in it to put the bone graft titanium mesh and then a full membrane covering. It has to at least cover the whole membrane and extend maybe a couple of millimeters from all sides. That also acts as an extra layer that the membrane has to perforate before going through the tissue. So that also decreases the risk of the exposure and also improve the quality of the bone.
Yeah.
The only difference.
Sorry to interrupt. You mentioned doing soft tissue graft for thickening the tissue prior to the augmentation. Some concern is maybe it becomes more scarred, so the advancement of the flap during the bone augmentation is going to be harder. So what's your comment on that?
So usually the scarring we see after many weeks a month. Honestly, I use a lot of free gingival grafts, whether around teeth or edentulous areas. And almost always in the first 4 to 6 weeks, that's the best time you should do the augmentation. If you leave a free gingival graft for 3-4 years, yes, you will start seeing some scarring. But also I've noticed a lot of the scarring is done when the free gingival graft is very thick. So knowing, which is a different topic, knowing how to do a free gingival graft and what thickness is required, and how to make sure the graft is very stable, all that adds to the quality of the tissue. But definitely, while the graft is still healing, 4-6 weeks maximum, this is the best time you go back. Honestly, I've never seen any scarring of free gingival graft in that time. I've seen grafts that were done many years ago and the tissue doesn't look very nice and it's scarred tissue, but early healing is the best time to go back and do GBRs.
I'm back.
Welcome back.
You know, now I want to ask you this question, because yeah, you were right. The type of the way that we do the free gingival graft, it definitely have an influence on the what happened to the tissue.
Sure.
But if you want to choose, I just want to know your experience and your preference. If you want to decide to do the thickening of the tissue through free gingival graft prior to augmentation when you think the tissue is thin, or
Yep.
doing this like connective tissue graft or put a dermal graft on top of your membrane for thickening the tissue, which one do you prefer if you want to choose for your patient?
Okay. So I'll tell you why I prefer always to do the tissue graft before GBRs. Not only it improves the handling of the tissue and decrease the risk of the perforation, but also it added more blood supply. So always with any regenerative procedure, there's a lot of, the body sends a lot of blood supply and a lot of BMPs naturally and a lot of growth factors. All of them are in the area. It's almost like a hot lesion. So taking advantage of that and then putting another surgery is very important. Also doing a free gingival graft increases the vestibule. So as I showed with the case with the maxillary posterior defect, we had no vestibule. So the free gingival graft not only increases the thickness, but the width of the attached tissue. That made it much easier for me to have a primary closure and also to have a very thick layer covering the titanium mesh. Sometimes I can use a very thin connective tissue graft on top of the titanium mesh or on top of any GBR. But for huge defects, soft tissue defects, a free gingival graft and doesn't affect much the healing time. We're talking about like only 4 to 6 weeks, and we can go back and do the second procedure. But this is my preference. I always do it before, unless if the tissue is thick, or at least have at least 1 millimeter thickness. I do tissue grafting at the end after implants are placed, but this is for a different reason. Yeah. Like the case where we did the full mount titanium mesh.
So Peter, in cases that I truly agree with you on that, but in cases that we want to do the soft tissue graft first, don't you have a concern that during your vertical, especially vertical and horizontal augmentation in combination, you lose the vestibular depth again because you're doing the coronal?
Yes.
And maybe there is a need for another soft tissue graft at the end of the procedure. So in your decision making, is it a factor or not?
So you're right. We definitely lose the vestibule again with the vertical augmentation. But then comes the role of the uncovery of implants, where I'm going to apically position all that back. I rarely need to do another tissue graft, but I can see maybe possibly happening. And usually I decide that at the time of the uncovery of the implants. But definitely you lose the vestibule and all the tissue graft is up. I had one time a patient called me on the phone and asked me like, I feel like the vestibule is gone. I feel like when I put my finger there, like there's no depth. I told her like, don't worry about it. When we go back and place the implants, we return it back to the same position. So it's definitely a concern. But then that comes the role of tissue grafting at the end as well. So at each surgery, we have to look and think about the tissue. As David Garber said, like tissue is the issue. So the GBR, and then at the time we're placing the implants, and also at the uncovery time, all these are times we can go ahead and improve the tissue by adding tissue graft, apically positioning flap, or the way we do the crystal incision, maybe more palatally to move more tissue to the buccal. All is important.
Yeah, absolutely right. And you know, you talked about, as you said, also it's a controversy, but you talked about decortication. And as you said, if we have 100 articles, 50 are against, 50 are, in favor of doing decortication. But my question is this, especially we sometimes face these cases in the posterior mandible, but most especially in the anterior zone, that have lost teeth for many years. And sometimes the ridge is paper thin. So it's almost cortical with 1 to 2 millimeters only.
Yes.
Even if we do the decortication, there is no spontaneous bone to make any blood come out. So in those cases, usually the main concern is vascular supply to the graft, no matter what technique that we are utilizing. I want to know, what do you suggest in those cases that the ridge is paper thin, there is no spontaneous bone, we may have enough height, but we might need to do the horizontal, but there is nothing to stick to and nothing to ensure for the vascular supply. So what do you
Yes, yes. So these cases actually, you're right. Like if you drill through the bone, like there's no medullary bone, it's all single compact layer. These cases, I would actually do some decortication, but for a different reason. I will do it to increase the mechanical interlocking between the graft and the very thin buccal or compact bone. And for these cases, I found that using actually chin blocks or Corey plates do better results compared to GBRs. I've had cases when I used to do GBRs in these areas. When I go back to drill for the implants, I see the GBR actually separating from the very thin native bone. And that's not as much with block grafts or with Corey plates. I see it more happening with GBRs. So the decortication maybe has a benefit in here, not to improve the native blood supply or the bone marrow access, but more to improve the interlocking with the new graft. But these cases, I see that the gold standard still the autogenous, and for these cases, you just go down a little bit more. If it's fully edentulous, there's no risk of paresthesia to the anterior teeth or needing for endo because the teeth are gone. And you can, with a good CBCT and studying the chin area, you can definitely have a block graft or a Corey plate, and all you need to do is just move it more coronally and stabilize it with screws, and usually get very good results in these areas. But this is a challenging area for sure.
Very challenging. And in continuing of this case, I want to know if you have any experience or what do you think about techniques like the SMART technique introduced by Ernesto Lee, or even the previous tunnel approaches that they pack some non-resorbable graft materials like HA or Xenos to have a contained area and wait for bone formation. Actually, sometimes they work, but also I want to know your experience on those techniques.
So honestly, I've tried them. I've tried doing the, I didn't take the course, the SMART technique course, but I tried using xenografting with the Gem 21. And honestly, what I noticed, without using a membrane, you don't get good results. You don't know what's inside the bone. Although if you take a scan, you will see the bone graft. You will see the xenograft particles, not bone actually. The particles are still there, and probably there's some bone incorporated in it, but also I'm sure there's some soft tissue component in it. And honestly, I mean, if it's my mouth, I would like to have a membrane, especially around implants and in implant dentistry. Using membranes is very important to control the bone graft and also to prevent soft tissue invasion. But tunneling bone graft underneath the flap, I've tried it, and I don't see the results as predictable or as satisfying as when using membranes. And I don't see it even easier. Like, I know sometimes it's an easier way and it's much faster way, or less. You still get a lot of swelling. You still spend enough time, and I don't see it as a better option. But actually using membranes and opening a full thickness flap and doing a GBR or a block graft is much more predictable, at least in my hands.
Yeah, absolutely right. Absolutely right. So, your topic is very interesting, and we can talk about it like many. But I want to forward, and my last question for you is this. Speaking of growth factors, over the past years, usage of IPRF, APRF, Gem 21, BMP, and so many other things, mixing with the graft, put a layer on it, sticky bone, etc. Speaking of growth factors, do you think, is it necessary, I mean, for bone augmentation, not for the effect on the bone,
yes.
Do you think, is it necessary to use them? Or in your practice, didn't you find comparable results when you use them or not using them? I want to know your experience. Sometimes the thing that usually we might get is that sometimes over treatment is happening in the practices. It's for photography or for case presentation is beautiful, but the result that you're going to gain, is it really necessary to go through all those processes or not, in your experience?
Yeah, I actually agree with you. It's many times I used to use a lot of different Gem 21 and use even infused BMPs. And then I decided to stop using them for a while. And I found that you can get very good results as long as you know you follow the basics, you know how to stabilize the membranes, to soft tissue handling, and you can get very good results. The only benefit I can tell you, and I'm gonna put PRF in a side and then put like PDGF and BMPs in one side. PRF, I didn't find any improvement at all. I'll be honest with you, only in tissue handling, but in quality of bone, whether you mix it with the bone or you put it over the bone, improves the tissue quality, and you can see the suture line healing faster, less painful. But I'm talking about quality of bone, no. With Gem 21 and BMPs, what I noticed that you can open the area faster. And that's the only advantage, I would say. If a patient has to travel or lives overseas and wants to cut the healing time for a month or 2 months, then maybe I will add Gem 21 and BMPs, and I will take the risk of opening for placing implants a bit earlier. But if you wait enough time, there's no difference. I mean, we're waiting 5 to 7 months.
1 month?
1 to 2 months faster. So if something I typically, yeah, if I something I typically like large GBR, I typically wait 6-7 months. I can open in 5. If maybe 5-6 months, I can open at 4. But I use Gem 21 or BMPs in these cases, and as I tell you, I use them maybe twice a year, very rarely now compared to how much I used to use them. Especially during like our training, we used to use them a lot, and we try to experiment different bone grafting. But also you have to see what is the added cost. Is it worth it to go through the added cost? Many times it's not.
Yeah, absolutely right. Because
Yeah.
I think so many people have, it was also my question, because in my experience, I really didn't find, we don't have BMP actually that much. It's not routine. We have it. Some companies bring it, especially those we have is from Korea. But
Okay.
PF or something like that, it's available. Also, we don't have Gem 21 in Iran, but that was always my question, that using these materials, especially the additive costs that come to the
Yes.
patient, is it really necessary, or the results going to be that much significant if you use them comparing not to using them? So that was why I asked you the question, Peter. Peter, really thank you so much for your time, for sharing your
Thank you, Omid.
cases. It's not a compliment. It was actually the real thing that we all
No.
saw. And thank you for the exact to the topic, exact to the point presentation and going through the details. And I'm so glad you accepted, and really looking forward to see you very soon in person.
Thank you so much for the invitation, Omid. It was my pleasure, and I enjoyed the discussion, honestly, and the very great questions asked. And hopefully we'll meet very, very soon. Thank you so much, Omid.
Sure. Stay safe and take care, my friend. Hats off.
Thank you. You as well. Thank you, man.
Bye.
Bye-bye.